Hello everyone. Primary angle closure glaucoma is usually seen in older patients aged more than 40 years. The occurrence of angle closure glaucoma in young patients is atypical. We present two young patients less than 30 years who presented with features of primary angle closure glaucoma. Their clinical features, management and post-operative course are discussed in this video. A 28-year-old male presented with diminution of vision in both eyes for the past 1 year. On examination, he had visual acuity of 2600 with rhegmatogenous retinal detachment in the right eye and detached retina showing intraretinal sciatic cavities. The left eye had a visual acuity of 2200 with closed angles, clear lens, high intraocular pressure with moderate disc damage, and OCT revealing intraretinal sciatic changes and subretinal fluid in the macular area. The patient underwent YAG peripheral iridotomy in the left eye and was started on anti-glaucoma medications. For the right eye, vitreoretinal surgery was performed for RD and the vision improved to 20/50 with an IOP of 13 mmHg. Disc showed a 0.5 CDR. Despite YAG peripheral iridotomy, angles were closed and the IOP in the left eye remained uncontrolled at 42 mmHg on maximum medical therapy, necessitating trabeculectomy with mitomycin C. Post-operatively, he had good bleb, no leak, shallow to flat anterior chamber despite cycloplegics, and no posterior segment pathology such as choroidal detachment or suprachoroidal hemorrhage were noted. The IOP was 19 mmHg on one topical anti-glaucoma medication and iridotomy was patent. All features pointed towards aqueous misdirection syndrome. Conservative management did not help, and since the patient had extremely shallow AC with extensive posterior synechiae and AC unlikely to deepen with cycloplegic treatment, we decided to go ahead with surgical management of malignant glaucoma. He underwent pars plana vitrectomy with lens extraction with IOL implantation combined with iridojonulo-hyaloidovitrectomy. Following this intervention, AC deepened significantly and the IOP was well controlled without any anti-glaucoma medication. Similarly, another patient, 19 years old male, presented with gradual painless diminution of vision in his left eye for the past 2 months. His visual acuity was 20/40 in the right eye and 20/100 in the left eye. Both eyes had high IOP with closed angles and advanced disc damage, and OCT revealing intraretinal sciatic changes and subretinal fluid at the macular area. Both eyes underwent YAG peripheral iridotomy and were started on anti-glaucoma medications. Despite maximum medical therapy, his IOP remained uncontrolled. Considering the high risk of malignant glaucoma, based on the experience of our first case, we performed trabeculectomy with mitomycin C and prophylactic iridojonulo-hyaloidovitrectomy in both eyes, left eye followed by the right eye. This animation video demonstrates the surgical procedure. In aqueous misdirection syndrome, there is an altered interaction between the ciliary process, lens and anterior vitreous phase, leading to anterior rotation of the ciliary body. This results in posteriorly directed flow of aqueous and subsequent collection of aqueous pockets in the anterior vitreous phase, causing vitreous swelling and axial and peripheral shallowing of the anterior chamber. The objective of IZHV is to create a direct communication between the anterior chamber and the anterior vitreous, clearing all obstacles in between, thus deepening the AC and reversing the pathology. After completing trabeculectomy, a clear corneal paracentesis is created using a 20 gauge MVR blade at 3, 7 and 9 o'clock position. The AC is filled with viscoelastic. The vitrector with the cutter facing inferiorly is introduced and advanced towards the 5 o'clock position, creating a peripheral iridectomy of adequate size. It is essential that the iridectomy opening is adequate to allow the vitrector to be positioned vertically downwards for focal jonulectomy and anterior hyaloidotomy at the iris root. After focal jonulectomy, vitrector is further advanced to perform anterior hyaloidotomy. The end point for IZHV is sufficient deepening of the anterior chamber and formation of a unicameral eye with unobstructed communication from the posterior chamber to the anterior chamber. Retroillumination helps visualize the opening in the capsule, ensuring no obstruction that could lead to failure and recurrence of malignant glaucoma. Post-operatively, his IOP was well controlled at all his visits with deep AC and with patent IZHV opening. We performed genetic testing in both patients considering the atypical nature of the disease, and both patients were positive for autosomal recessive bestrophinopathy with mutation in BEST1 gene. In the first case, as the patient underwent vitrectomy as a part of RD surgery, he never had angle closure or high IOP or disc damage in the right eye. And the reversal of malignant glaucoma following vitrectomy with IZHV in the left eye would point towards inherent vitreous pathology. Thus, to conclude, atypical angle closure glaucoma in young patients with bestrophinopathy are refractory to medical treatment and often need surgery for IOP control. However, glaucoma surgery is associated with high risk of malignant glaucoma. Since the pathology appears to lie mainly in vitreous, pars plana vitrectomy with IZHV with or without lens extraction seems to control IOP and prevent malignant glaucoma. In a case trabeclectomy is planned, it should be combined with IZHV. A detailed retinal evaluation and genetic testing are essential in these patients before planning any filtration surgery. Thank you.